In healthcare, not every problem is a design problem, and not every solution requires building more space. In this episode of The Architecture of Healing, we're joined by Cynthia Hayward, a pioneer in healthcare facility planning whose work has shaped how organizations think about space, strategy, and operations. Drawing from decades of experience in the development of the SpaceMed guide, Cynthia challenges the traditional wish list approach to design and introduces a more disciplined and data-driven way to align space with real clinical needs. From avoiding costly overbuilding to designing for flexibility in an era of rapid change, this conversation reframes how healthcare leaders, planners, and designers can create environments that truly support care delivery. Welcome to the Architecture of Healing. I am so excited for today's episode. I am joined by Cynthia Hayward. This is just such a privilege to be able to chat with her. I have used her book, SpaceMed, early on in my design career and really cut my teeth on healthcare as I learned from a lot of the resources that she helped to develop. So thank you for joining us today, Cynthia. It's a pleasure to have you on the show.
Thank you for inviting me.
As we jump in, you spent over 40 years shaping healthcare facility planning, capital strategy. You founded your firm, Hayward and Associates, to really focus in on pre-design and planning. How did you come to find healthcare and healthcare design as a field and really get into planning?
Well, I was finishing my Master of Architecture degree at the University of Michigan in the mid 1970s. And that was at the tail end of the global energy crisis, and there were very few jobs for architects. I had a drafting job with an engineering firm on weekends. And one Saturday afternoon, as I was leaving my drafting job, I could see a flurry of activity through the glass doors of another business in the same building. I could also see architectural drawings mounted on the conference room wall. So I just walked in and asked what they were doing. They were a healthcare consulting firm and had just been awarded a large contract to plan a new hospital in Tempe, Arizona. And when I told them I was just about to graduate from architecture school, they asked if I wanted a job. Of course I did. So that was the start of my career path, both in healthcare and in pre-design planning. The firm was called Chi Systems, named after the Greek letter and statistical symbol, the X. And it was founded by several industrial engineering graduates from the University of Michigan. The university had one of the first programs that combined industrial engineering with hospital administration. So they were also focused on the healthcare industry. They had also developed some of the first staffing standards for hospitals. I think not everyone knows what industrial engineers do, but they combine engineering and business principles to optimize complex systems and processes. So their focus is to improve efficiency and productivity and quality. Yeah, this sounds a lot like lean process redesign as we know today. Also, as a healthcare management consulting firm, they had a multidisciplinary staff with nurses and physicians and equipment planners, finance people, in addition to industrial engineers, and they only had one architect. So this is where I learned to apply the traditional industrial engineering approach to space planning. That is, analyzing a hospital department's processes and then identifying what actually drives the need for space. I also learned that what a client perceives as a facility problem often didn't have anything to do with facilities. Basically, management consultants are problem solvers. We focus our analysis on a foundation of data rather than just asking the staff what they perceive as their issues. And, well, of course, architects are problem solvers too, but they sometimes see problems as design problems when actually they may be a management or an organization problem that can be solved by a policy decision.
So in your early work and some of your work with the Canadian Department of National Health and Welfare and your involvement with AIA's programming framework, how did that influence your philosophy?
I became involved in developing space planning guidelines very early in my career. In the 1980s, the Canadian Department of National Health and Welfare issued a contract to develop a series of space planning methodologies. They were to be used by individual provinces in assessing and planning their hospitals. So as the project director, my first task was to review planning standards and guidelines that were already used across North America. The U.S. Department of Health and Human Services, they had published minimal guidelines at that time, but they only recommended specific rooms to be included in a general hospital. And there were really minimal guidelines relative to the numbers and types and sizes of spaces. So other than that, there were just prescriptive rules of thumb, which were sometimes published, such as recommended square feet per bed for different departments. These seem somewhat comical today. For example, your surgery suite should be 12% of the total hospital space. So these really were not very valid as guidelines or standards. Also, it was very difficult to apply these standards because of confusion with terminology and what was included and what wasn't included in the space. So in the Evaluation and Space Programming Methodology series developed for Canada, we used the traditional industrial engineering approach to develop a more rational method of space allocation based on a detailed analysis of the actual needs of the department, staff, and the users of the space. So our approach separated the process or the methodology from the actual numbers. The process was based on a detailed analysis of a department's unique service mix, their workload, their staffing, their equipment, and other factors affecting space. And while the process would generally not change over time, the numbers such as average treatment times and types and sizes of spaces could vary from hospital to hospital as medical practice and technology changed. Although these were financed by the Canadian government, these methodologies were actually widely used by regulatory agencies and facility planners throughout the U.S. over the next couple of decades. And then during that same time, I was involved with the AIA's Committee on Architecture for Health, which it was called at the time. And because I was active in their programming subcommittee, they asked me to write a white paper. It was titled A Generic Process for Projecting Healthcare Space Needs. And this document was actually published by the AIA in 1986 and established pre-design planning as a formal phase of the design and construction process. It became known as the functional and space programming process. And the intent was for the functional and space program to be developed with users and that the department staff would sign off on it before a design architect actually started schematic drawings. At the same time, the U.S. Department of Health and Human Services asked the AIA to assume responsibility for overseeing their guidelines. So the guidelines for construction equipment of hospitals and medical facilities under the AIA Committee on Architecture for Health was first published in 1987. And this eventually evolved into the FGI guidelines, which has been published under the direction of the Facility Guidelines Institute since 2001.
Maybe leaning into that question a little bit further, you spoke to the influence of industrial engineering in early healthcare design and planning with those workflows and processes. Today, there's a lot of lean workflows and lean methodology built into healthcare operations. As you were developing that, was lean something that was being discussed? Was it in the forefront in its infancy? Was that at all in the conversation?
No, not at all. The lean process we designed really just evolved over subsequent years. I think it was first used at the Toyota factory in Japan. No, basically, industrial engineering principles was the only sort of focus for productivity at that time period. All of the lean process design, quality, total quality improvement, all these other acronyms that evolved over the last 20 years were really relatively new.
So you were definitely on the cutting edge and the forefront of that as it was making its way into the healthcare space. And so through that influence, you then made this transition from practicing in say a larger organization to your own consulting practice and leading your own firm. How did you get there? How did that shape your perspective and say, hey, I want to go out and create Hayward and Associates?
Well, I was a partner in Kai Systems for about 20 years, and we sold the business to an IT company that was also focused on the healthcare industry. I was fascinated with the whole technology boom and potential impact on the healthcare industry. So I continued working with the new company for a couple of years. I was an early adopter of everything electronic. I was a whiz with Excel spreadsheets and web technology. And this is where actually I got the idea for the SpaceMed guide. So I started Hayward and Associates in 2003 because I really wanted to spend more time consulting with clients rather than managing a lot of people. And in addition to the construction of many outpatient facilities at the time, there was lots of opportunities for resizing and retooling existing facilities. I was also excited about reimagining how healthcare services would be delivered in the new e-health environment, as it was known at the time, with electronic communication, the internet, wireless technology, and the melding of medical technologies on the horizon. It was also a new challenge for healthcare organizations because they were faced with balancing spending money on bricks and mortar versus on IT and new medical equipment. However, I saw a lot of overbuilding and supersizing of facilities. Another factor was the intense competition between hospitals. Large amounts of space and new facilities were sort of part of the arms race among physicians and between competing hospitals. So throughout the next 2 decades, I developed a reputation for providing a second opinion when grandiose master plans became unaffordable or large projects grew out of control. The CFO and board were usually involved in putting the brakes on these supersized projects, not only because they couldn't afford the initial capital costs, but because of the long-term operational costs. And I have to say, when faced with a facility planning project that's taken on a life of its own, it's hard to stop or slow down the process. There's a critical point where everybody focuses on whether the project is on time and on budget, and they forget, is it, as they used to say, on target, and is it the right solution to the problem? So when projects are postponed indefinitely or downsized, this is a difficult time to start working with a client. You have to communicate the unmet expectations back to the disillusioned physicians and department managers, and of course, morale suffers. This process actually reminds me of the circus clown who opens the can and everything pops out, and then you have to kind of stuff the contents back into the cans.
Yeah, I love that analogy. And stopping a project of such scale is a huge undertaking. It's this giant boulder rolling downhill, and it's got so much momentum just to stop that in its tracks and say, are we really doing the right thing for our community and for our
Mhm,
patients? And
mhm.
and honestly, I find in those times where you have so many constraints and so many walls, and you find you're back up against a corner, that I think is where true innovation lives. That's where you start to see those new ideas that come out of, well, we have no other option but to do something like this.
Yeah, right.
And you really are able to push the envelope and try new things. So you started your firm, and then you began developing SpaceMed in 2004 with the first edition. At the time, what gaps in practice and education were you aiming to fill with the creation of SpaceMed?
Well, with all the resizing work that I was doing, it seemed like the traditional facility planning process was really part of the problem. And there was little appreciation for space as an expensive resource. Many facility planners and architects were using what I call the wish list approach to space planning. That is, they would go to the department staff and say, "You're the experts, so just give us your Christmas list and we will build it." There was also other inappropriate projects based on recruiting promises to physicians or based on the wish lists of donors. But often the most local staff during the planning process weren't even around when the facility opened. So keep in mind that when I was in architectural school, and I don't know about you, Chase, but the programming stage of a project was always described as listening to the client.
Absolutely.
So this is how many architects are trained. We always focused on the project and never talked about operational costs or creative ways to avoid building altogether. So I developed the first edition of the SpaceMed guide really as a pre-designed planning tool to use a more rational approach to space planning. I wanted facility planners to understand that for any given workload to be accommodated, there are many ways to organize, staff, equip, and configure the space, and that decisions made at this stage have the most impact on ongoing operational costs, as well as future flexibility compared to the initial cost of the bricks and mortar. I also wanted to, let's say, democratize and demystify the space planning process. So with a step-by-step workbook and Excel space planning templates, facility planners really can work with the staff who are expected to occupy the space and quickly determine the types, numbers, and sizes of spaces. And healthcare systems could also develop the functional space program with their own staff for smaller projects. Also, a lot of architectural firms may not have the breadth and depth of experience in hospital operations. So by facilitating the whole functional space programming process, architects can get on to what they most like to do, which is start design. It also allows them to guide user groups through a process that would reflect the space that they actually need rather than their wish list.
Yeah.
The approach that I used for the SpaceMed guide really was based on a couple of key principles. The first is that you need to look at a large medical center, and all space is not really the same in it. It's made up of various different building types. So each of these may have to comply with different building codes or meet different access and egress requirements or have different renovation costs and reuse potential. So by deconstructing the space, you can determine the specific space drivers for each major category of space. For example, inpatient nursing units, they need to comply with the most stringent building codes because the patients are not ambulatory and they stay for an extended period of time. The construction is modular and not very adaptable for reuse. On the other hand, if you look at diagnostic and treatment space, it's most impacted by rapidly changing technology and requires highly flexible space. And its footprint is directly impacted by its workload and throughput, generally determined by the age of the equipment and the hours of operation. And then you have physician practice space, which needs to provide convenient access for its ambulatory population, as well as a productive work environment for physicians. Then you can jump to customer service space and amenities, which vary widely from organization to organization, depending on their policies and their financial resources. And then a couple of other categories of space. You have administrative space, offices and workstation for staff that aren't involved in direct patient care. And this space would be just like you'd find in an office building. And of course, it can be located in an office building and doesn't even need to be in the hospital. And then the last category of space, building support. I also call this hotel services. Any large hospitality complex needs a food service and housekeeping and security and materials management. And this is very different space than that required to provide direct patient care. So if you organize clinical services and support functions this way, it provides a flexible framework. That was really the first principle. The second principle was the SpaceMed guide also deconstructs the space within each department or functional area so that planners can better understand what drives each individual space. And then each individual room is also identified as whether it is workload dependent or variable or fixed and optional. So this way of deconstructing the space really helps planners understand exactly what is driving each space. And then finally, the third principle is that the SpaceMed guide focuses also on identifying common spaces that can be replicated across departments. So this not only provides future flexibility, but of course added cost savings when rooms serving comparable functions are similarly sized and finished instead of being tailored to the individual occupants.
You mentioned that key objective as you come out of architecture school is listening to the owner and listening to the client. I love that. That's so true. I think back to another book that was really instrumental for me. It's called Problem Seeking. And if you spend 90% of the time trying to identify that problem, the solution almost presents itself, right? And so it's almost like your work with SpaceMed and these benchmark guidelines help to articulate the problem so you're not trying to solve for problems that aren't really problems, right? It's
exactly, yeah.
I wish we could have this. Okay, that's awesome. But how does that impact the ROI? How does that impact the efficiency of the department? Let's figure out what that problem is and really drill into that. And then maybe that does come with your wish list and some of those things on there. But maybe there are bigger fish to fry, so to speak. As you talk about the different departments and the different components of SpaceMed, is there one that maybe you enjoyed working through more so than others, or was there one that may have been more challenging to figure out what those benchmarks and outlines were?
Well, I don't think one is more challenging than the other. I think it's just trying to deconstruct the space for facility planners so that they can see that each of these different building types that make up a large medical center has different drivers and different things that impacts the space. Now, of course, not all facilities will have all categories of space, but for many years, for example, administrative offices, they were buried in small pods within every department. And then when those staffing positions change and organization structures are changed, you end up with these small pods of space that are not well utilized. And also, departments then become very possessive over space by creating a generic office space in a single location. That space can be reassigned over time as job descriptions change and organization structures change and so forth.
You mentioned some of the changes to those departments, the evolution over time. So SpaceMed's now in its fourth edition in 2022. What's driven some of those changes over that span as you've iterated from version 1 to 2 to 3, now to 4, through changes in evidence-based design, industry trends? What's really driving the successive iterations, and how has that evolved over time?
Over the years, as I mentioned, the difference between the process and the numbers, the types of rooms and room sizes have changed, which is the numbers, but the overall methodology or process really has pretty much remained the same. One thing that was key is I aligned the SpaceMed guide with the FGI guidelines. The SpaceMed guide actually complements the FGI guidelines by helping planners develop the functional program, which is required before applying the guidelines, and also to develop the room by room space programs that's needed before schematic design can be started. So I use the same terminology and required spaces and minimum room sizes that were specified in the FGI guidelines. This was easier to do because over time, the FGI guidelines actually started to also focus on common spaces, which were consistent with the philosophy of the SpaceMed guide. A prep and recovery space is the same space, whether it's used to support an endoscopy suite or a surgery suite. 2015 also included metric version of the templates because a lot of purchasers were from Canada and other countries. And I think in 2017, I converted the hard copy workbook to the digital format because everybody wanted
Yeah.
to carry it with them and so forth. Let's see, the fourth edition, which was released during the second year of the pandemic, that really had the most significant changes. I'd say some common themes through the workbook were probably, aside from planning during times of uncertainty, the increasing use of imaging across all medical specialties and the rapid evolution of automation and robotics, as well as adapting to new safety protocols and the impact of telemedicine on facility capacity. Also, in the last edition, surgical and endovascular services were combined into a single section to reflect the melding of interventional radiology and minimally invasive image-guided and traditional open surgical procedures. So this new section clarifies the differences between operating rooms and procedure rooms and imaging rooms and so forth. And I also put together a single section for diagnostic services, including diagnostic imaging and other technologies, which are very often today merged into a single diagnostic center, whereas in the past, each technology may have had their own department. The clinical laboratory and hospital pharmacy sections were revised to reflect the increasing automation and robotics. If you walk into a clinical laboratory or hospital pharmacy today, they're like a high-tech manufacturing plant with very little human intervention. And these areas need to be planned closely with the vendor because of their complexity. Also, the equipment may be leased and updated and even maintained by the vendor, even though it's located in hospital space. Ambulatory care section reflects the impact of increased telehealth visits, which was a big outcome of the pandemic.
Yeah. And thinking about the continued evolution, time will tell if we see a version 5 that takes AI into consideration and the influx of how artificial intelligence is changing the landscape of care delivery and the continued push towards outpatient procedures from higher acuity settings. As you look at this change and think through projects you've been involved with or organizations you've worked with, traditionally, where have organizations overcommitted space or under anticipated change as they are creating some of their projects?
Look at the past 20 years or so with the intense focus of moving outpatient services out of the hospital and into lower cost settings. There was definitely a build it and they will come attitude with a lot of dollars spent on renovation and construction projects that were not really supported by solid business plans. However, as ambulatory care centers seem to pop up everywhere, I think we forget that things were changing in the hospital as well, which also required a lot of reconfiguration. So while outpatient services were being moved out of the hospitals, such as diagnostic and therapeutic imaging and surgery and physical therapy, inpatient workload was also declining. And as inpatient lengths of stay declined, the overall tests per inpatient were declining as well. So there was also a focus on bringing services to the nursing unit rather than transporting patients to a large central department, which was assumed to be operationally costly. So, for example, instead of transporting orthopedic patients to a central physical therapy department, the therapists came to the nursing unit and provided therapy in the patient room or the hallway. So a large central physical therapy department became a thing of the past. And as a result, a lot of clinical departments and hospitals were sort of like ghost towns with their workloads significantly reduced, which made their operations even less efficient. At the same time, many of the new outpatient centers simply replicated the existing services that were in the hospital, and they had redundant equipment and staff and space. And in many cases, operational costs increased without any additional revenue, even though the new facilities might be somewhat more accessible to patients. But I think outpatient surgery centers are probably one of the successes, out needing to accommodate emergency surgeries and hospital inpatients, which often bumped more routine outpatient surgeries. The new outpatient surgery centers were actually able to turn over their operating rooms a lot quicker between cases, and they could accommodate a lot more surgery cases per OR in a given day. And so physicians and anesthesiologists could be a lot more efficient and they could make a lot more money working in this new environment. So there's a couple of examples of how we move things out of the hospital. At the same time,
Yeah.
we emptied the hospital out, and there were some successes and some failures in terms of the outpatient drive.
Thinking about your other book, Healthcare Facility Planning, Thinking Strategically, that's book's in its second edition and part of the American College of Healthcare Executives Management series, used by healthcare executives across the country, about reconfiguring, renovating, expanding, replacing a healthcare facility, and about how rare that opportunity is for an organization to undertake. Can you maybe cite an example from that book or from your work on how an organization has rethinked maybe some of their processes by using that as a resource as they undertake one of these new projects?
In the mid 2000s, a large healthcare system in the Pacific Northwest wanted to replace an existing hospital with a multidisciplinary ambulatory care center. And the facility would also provide physician practice for about 20 medical specialties. So the new center was to have all the services of the existing hospital, except for the inpatient beds and a full service emergency department. At the time, it was referred to as the hospital without beds. And this was because the new facility was to be located on the site of one of the larger hospitals. So they hired an architectural firm who took the project through the functional space programming phase. They actually even completed schematic design drawings. And in order to develop the space program, the architects met with the staff in user groups based on the existing hospital organization structure. However, what they ended up with was a building with a series of storefronts for each of the existing departments. It just didn't accommodate any inpatients. So the planning process had been underway for almost a year when they actually asked me to provide a second opinion. I think the client recognized that the new facility was just replicating the existing hospital department silos and inefficient processes, and it didn't really reflect their visions for a new patient-centered, efficient, and flexible model for delivering outpatient care. So, with a small team, I facilitated multidisciplinary user groups to rethink the organization of clinical services and the facility layout. For example, one group focused on patient intake, processing, and customer service functions, regardless of what department they were currently assigned to. And another group was focused on routine tests and procedures, particularly those with a quick turnaround time. Their goal was to expedite service for these routine tests. Then there was another group that was focused on surgery and interventional procedures. These patients had different needs and concerns than those whose visits were routine. And other groups focused on the physician practice space and how to make it more efficient. We ended up with consensus on key facility planning principles, and we programmed the new facility with patient-centered multidisciplinary services that were also efficient to staff. We also developed things like a universal exam room size and layout and a flexible timeshare clinic module that could accommodate different specialties from day to day. And we had touchdown workstations for the staff in lieu of remote offices. So there was a lot of creative things that we did there. And the health system actually decided to incorporate the facility planning principles and the universal exam room size and the timeshare clinic model in their subsequent new and renovated outpatient facilities. This is an example of how you have to rethink the operational processes. You can't just go to the people that are currently engaged in the existing inefficient processes.
I love the way that you set those teams up because it wasn't the traditional thinking of, hey, this group's working on inpatient care and this group's working on the lab and this group's working on imaging. But you started with customer service, patients, and how do we provide true quality healthcare for patients? And you go into minor procedures and routine procedures and then more advanced or complex procedures. What are the patients there for? And then all of those other things such as lab, pharmacy, imaging, they intersect with those groups, but you're starting with the why, the patient's there, and how to move them through the facility and move them through the space in a strategic way. It's always been this department. Let's create a group to look at this department. So it's a different way of thinking. And I think that's very insightful into how you influence change when you're looking at a new model of care delivery. Zooming out, you've done a lot of work both here in the United States and with the Ministries of Health in Canada. What's that like? How do you balance both of those and maybe compare and contrast the differences of those two types of projects and systems at a strategic and facility level?
Canada has a publicly funded single payer health system. So there's an extensive pre-designed planning process to make a business case for funding any given renovation or construction project. Projects just don't get funded unless there's a detailed business plan and evidence that different facility solutions have all been evaluated. The provincial government sets the annual budget for each hospital authorities, which in turn sets the yearly budgets for individual hospitals. This, by the way, was quite interesting and surprising. Sometimes there may be a capacity issue with, say, ICU beds or ORs, a sense that we don't have enough ICU beds, we don't have enough operating rooms. When they actually have the physical capacity, they just don't have the budget to staff all the existing beds or ORs, so some are closed.
Yeah.
Sometimes people didn't even recognize that it wasn't a physical capacity, it was that there just were ICU beds that weren't open because they didn't have the budget that year for the staffing.
I actually encountered a similar challenge on a master plan post-COVID where they just couldn't hire the staff. We were looking at licensed beds versus staff beds, and many of these were at the time semi-private rooms. And so there were three metrics that we were tracking simultaneously. And so that does certainly add a wrinkle to how you study space when you have the space, but it's not able to be used for whatever reason. Do you find that there's any other core foundational differences between working on healthcare projects and with healthcare organizations in Canada versus the United States from a strategic lens, maybe return on investment?
Well, they were very slow to move outpatient services out of the house. We're talking maybe 20 years post the US moving a lot of services out of the hospital. I would have to say, though, in Canada, the professional organizations, whether it's the laboratory technicians or the pharmacists or the nurses or radiology techs, they have very strong professional organizations. So it's often difficult to look at cross training of staff without getting the buy in from the professional organizations. For example, who can draw blood? Well, the Association of Laboratory Technologists, of course, didn't feel like anyone else could draw blood, but there's many other specialties that certainly could do that. And this was at the time when we were looking at rapid response centers where patients that needed a quick turnaround, routine tests like a blood draw, a chest x-ray, and so forth, you wanted to get them in and out and cross-train staff. And that's often very difficult to do with strong professional organizations that protect their own turf, put it that way.
Absolutely. Looking into the future with AI, with technology, and with capital investments in facilities being one of the largest healthcare expenses aside from staff and people, you have to think about how to be nimble over time. Can you talk about how SpaceMed has shown ways to be flexible through planning and design, and maybe some ways that organizations may build in some of that flexibility?
I think the term future proofing, which is popular today, has been somewhat overused. It's sometimes repeated kind of as a mantra amongst healthcare facility planners and architects. But to me, it's just really what I've always referred to as flexibility. And if you look at the definition of flexibility, it really means adaptable or adjustable to change. But in reality, achieving flexibility often requires that physicians and department managers relinquish absolute control over their space and equipment for the good of the organization. That's a heavy lift in itself. Well, let's look at some examples of how a healthcare organization can achieve flexibility. So first, you can plan multi-use or shared facility components. This is like acuity adaptable or universal patient rooms, so they can be adapted for most levels of acuity by altering the staffing levels or equipment. This concept also can reduce patient transfers and improve the continuity of care and reduce medical errors and so forth. I talked about timeshare clinic space that can be leased by physicians by the day a week or when they need it, instead of exam rooms sitting empty when physicians are doing rounds in the hospital or involved in research or doing other things. You can have multi-use procedure rooms that can be used for different procedures by simply using different portable equipment. You can also redeploy space by shift. If you look at holding ED patients in the surgery suite recovery area for observation during the evening or while waiting for an inpatient bed to become available. And of course, you can co-locate different procedure rooms so they can share the same patient intake and preparation and support space. That's one way that we can achieve flexibility. Another way is to plan space that can be adapted over time. So, for example, you can have a flexible diagnostic and treatment center with a central patient reception intake area and shared prep and recovery area, staff facilities, and then just provide a mix of large and small procedure rooms where equipment can be changed and upgraded over time. This is in contrast to the traditional approach of planning dispersed and fragmented, as I refer to storefronts for each modality. You can have generic administrative office suites. You develop one large office suite for people that don't require face-to-face customer contact, and that space can be reassigned over time in response to organizational changes or changes in staff or moving people off-site. Another way of achieving flexibility is unbundling services from the hospital structure. Certainly, this can reduce an organization's initial capital investment but also facilitate the future relocation, contraction, or expansion as workloads and staffing and operational processes change. Most organizations have already moved routine, high volume outpatient services into separate facilities, either on campus or off campus. And certainly administrative offices is pretty common to move those into office buildings. But you can also consolidate building support services in a separate service building, such as your supply processing and distribution functions. This type of space is a lot less expensive to construct and can be easily renovated as technology changes. And outsourcing services or constructing shared facilities to support multiple hospital sites can certainly be advantageous, like warehouses and kitchens and laundries, even clinical laboratories. One other thing is leasing space rather than buying or building space. Certainly that would reduce the initial capital investment and long-term risk. For example, if a hospital is looking at starting a new program or service, it's a lot less risk if they put it in a lease space to see how the workload is going to evolve and how successful it will be before they actually build space or commit to space. Another area is leasing imaging equipment. Some organizations lease the equipment and pay based on its use rather than buying the equipment outright. And a hospital may also become a landlord and lease space within its facility to an outside vendor who operates a coffee shop or a restaurant or a gift shop or a pharmacy. Finally, building a flexible infrastructure with long-span joists and interstitial space provides a cost-effective way to adapt to ongoing changes over time. I always think that hospitals should be built more like shopping centers with a huge superstructure and interior spaces designed so that occupants can come and go over time.
That is a lot of things that organizations can do to stay nimble and flexible. And I am sure there's several organizations out there that can do all of those things, but I know that there's quite a few that have to prioritize in that list, right? It's, hey, we can do this or this. We only have this many dollars, and what's going to set us up for the future appropriately in our market and demographic. And it goes back to what we talked about earlier, just listening and hearing from the client, hearing from the community, and really thinking strategically of which one of these things is going to have the largest impact in the long term, and playing out scenarios to figure that out. As we come to a close, I'd love to explore some of the common pitfalls that you've seen in planning and master planning throughout your career so that folks such as me can learn and avoid some of those common pitfalls.
How about if I give you a list of maybe 10? Let's start with a very simple one. Confusing net and gross space. Department gross square feet, the footprint of a department, it could be 25% to 50% higher than the net square feet. And building gross square feet may be another 25 or 35% higher than the department gross square feet. So when discussing and comparing space, you need to always be specific. Number 2, very important, beginning schematic drawings before the functional space program is completed and approved. This can result in scope creep, and the eventual size and cost of the project may escalate out of control. Tailoring new facilities to the idiosyncrasies of specific department managers or physicians. The current leaders may not even be around when the facility is open, and the new people might want to instigate a whole new cycle of renovation projects.
Yep.
Okay. Planning additional procedure rooms, equipment, and expansion space for overly optimistic workload growth. Using the whole build it and they will come approach, which you may end up with simply increased labor and facility costs and no additional revenue. Another is duplicating current inefficient operational systems in new space. Then let's look at neglecting to consider the impact of new medical equipment on procedure room throughput. So this can go both ways. New equipment may allow you to increase throughput significantly and perhaps reduce the need for additional procedure rooms, but you may need additional support space to move more patients through the department. On the other hand, when you install new state-of-the-art equipment, such as a hybrid surgical equipment in the OR, it may take a year or more for the staff to actually get up to speed and start becoming productive. Here's another one, not planning for less efficient space utilization when retrofitting existing space in a new or for a new function. So older buildings are typically less flexible and have more unassignable space. You may have fixed bay widths or column spacing or mechanical chases and load-bearing walls and partitions that maybe can only be removed with great difficulty and at a great cost. So you need to plan more department gross square feet than you would need in new construction. Let's see, how about simplistically categorizing patients as either inpatients or outpatients? So inpatients can vary from those acutely ill to those who have a short stay and are undergoing a routine procedure. At the same time, outpatients can range from those seeking care for a life-threatening condition to those focused on wellness or fitness. And each type of outpatient has different needs and expectations relative to the site access and wayfinding and convenience and recognition by staff when they arrive and whether they need discharge instructions and so forth. Two last ones, thinking that new facilities are the panacea for customer satisfaction. So it's actually a lot easier to plan a new building than to tackle issues with unhappy staff. I think of 30 years ago, Press Ganey started surveying customers about their experiences with healthcare services. And although patients were asked about whether the facilities were clean and comfortable, the number one indicator as to whether they were satisfied with their visit was how they were treated by the staff. Now, if you fast forward to the 2025 Patient Experience Report by Press Ganey, and the primary driver 30 years later of satisfaction still revolves around the experience with the staff, specifically whether the customer experienced teamwork, which in turn made them feel safe. So we can't forget about the focus on staff and teamwork. It's not all about the facilities. And finally, number 10, forgetting to ask the question, what happens if we don't build any? How can we retool or reconfigure our existing facilities to actually avoid an expansion or construction project altogether?
Yeah. I love your comment about staff. And I think that that's so important now because it directly impacts the patient and customer experience. And so, how do we elevate our staff in healthcare facilities and create space for them to decompress, to have a break, to have something that they can personalize and really own in a larger space in that healthcare organization? Not only is that going to affect their own well being, but it's going to waterfall into the patient experience and how they treat and care for those patients while they are at the facility. So that's huge. Is there one thing that you wish that planners and architects could better understand about planning healthcare facilities when they're working through master plans or pre-design or whatnot?
Yeah, there's not enough understanding of how operational issues faced by healthcare facilities are interrelated and not always a facility problem. So let's look at the ED, where overcrowding is a continual issue. So in the past several decades, there was a lot of focus on reducing the length of stay in the hospital, along with the shift to providing care in an outpatient setting. So we reduced the number of inpatient beds. However, if you want to reduce the length of stay, you have to have somewhere for patients to be discharged to. And so if they're not able to go home, you have to basically have skilled nursing or long-term care facilities. Otherwise, the patients just back up in the hospital. And when all the beds are full in the hospital, then patients in turn back up in the ED. So then we have increasing numbers of uninsured people. ED visits start to rise. So if a person can't afford to see a doctor, they may wait until their condition is severe, and under law, an ED can't refuse to provide care. So we have patients backing up in the hospital with no place for them to be discharged. And then this is complicated by an increase in patients without insurance arriving at the ED. This is really the perfect storm, and we have gridlock. Now, another related issue is patients who are designated as outpatient observation status. Medicare Advantage, the private Medicare alternative pushed as a way to reduce costs, has long relied on extended observation stays to avoid admitting patients, a strategy that basically helps those for-profit plans to reduce their costs. But this then shifts the financial burden onto hospitals. So a patient may be in outpatient observation status for up to 24 hours or more in some cases. But unless the hospital has a separate observation unit, these patients also back up in the emergency room. However, Medicare Advantage observation patients are reimbursed at half the rate of traditional Medicare patients, or in some cases, not at all. So then how can the hospital justify creating a separate observation unit, adding more fixed staffing costs, or do they just keep patients in the ED and overburden the ED staff? Now, another option, which is the most common, is to just expand the ED and to keep making it bigger, even though it means increased operational costs with little increase in revenue. So here's an example of how there's so many interrelated problems, and just expanding the ED is not always the answer.
That is so complex and so connected, right? It's operations, it's integrating the payers and how they pay for services, which ultimately impacts organizational strategy on how you align your future growth and expansion models to be reimbursed appropriately for patient care, and making sure that that patient care is being performed in the right care delivery setting with the right qualified staff.
Mm-hmm.
And as that evolves, can those observations be done remotely at home through technology? Maybe. Are they
That's a
reimbursed
good
the same?
point. Yeah.
I don't know. So the story's still being written. And that's one thing that I really love about healthcare and where we are at this inflection point in healthcare. And there's so much still yet to do. Now, jumping into our lightning round, I'd love to just hit these 4 questions as we wrap up here. What is one of your favorite healing spaces?
Outdoors and in nature.
Yes. I did a lot of that this weekend. It was beautiful here. What inspires you outside of work?
Oh, I would say working in my garden or hiking in the woods. I also like to travel. I think I've visited some 40 countries so far. Every
Wow,
culture has something new you can learn.
that's fantastic. And what is a book that has changed the way you think?
Well, it would have to be The Tyranny of Merit by Michael Sandel. He challenges the idea that anyone in the U.S. can simply pull themselves up by their bootstraps if they just work hard enough. Instead, he says we live in an age of winners and losers, and the odds are definitely stacked in favor of those who are already fortunate.
Hmm. And finish this sentence. The future of healthcare is blank.
The future of healthcare in the U.S. will depend on whether the American people decide that affordable healthcare is a right or a privilege. I guess particularly considering that we are the wealthiest country in the world.
Cynthia, this has been truly an inspiring conversation. I have loved going deep in some of these topics with you and just hearing your passion behind why you do what you do and the mark that you have left in healthcare design and planning over your career. It's truly impactful. I know it's impacted me in my journey as a healthcare planner, designer, and strategist, just thinking big picture strategy and how to align healthcare organizations for future long-term success. So thank you. Cynthia reminds us that great healthcare environments don't start with design. They start with clarity. Clarity about the problem, the processes, and the long-term implications of every square foot. Whether it's resisting the urge to overbuild, rethinking outdated operational models, or designing for flexibility in uncertain times. The opportunity is to be more intentional and more strategic at every step. If this conversation sparked new thinking for you, share it with a colleague, subscribe to the Architecture of Healing, and leave a review to help others find it. And as always, keep asking the question, are we designing the right solution or just building more space?